Good morning, good afternoon, or good evening, everyone, depending on where you are calling in from, and welcome to our second Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. I'm your host, Bruce Hall, and before we begin, I'd like to go over a few disclosures. First of all, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp. And Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. And now it's my extreme pleasure to introduce our guest today, Dr. Javier Lasa. Dr. Lasa is an attending physician in the cardiovascular intensive care unit at Texas Children's Hospital and is an assistant professor of pediatrics at Baylor College of Medicine. Dr. Lasa will be discussing how he and his colleagues at Texas Children's use clinical data and remote monitoring tools to better manage children, including the youngest of all children, neonates, with critical congenital heart disease in everyday patient care. Dr. Lasa has some disclosures of his own that you can see on this slide. And I'll say, how are you doing today, Dr. Lasa?
I'm doing well. Thank you, Bruce.
That's great, and great to have you with us. And our format today is first, I'll ask you some questions to give you the chance to present your study to our audience members who will remain muted. And during our talk, audience members can type any questions they may have in the Q&A tab. And at the end of your presentation, we'll address as many questions as we have time for at the end of the session. Does that sound good?
That sounds great. Again, thanks for the invite.
Absolutely. Very good. Okay. Let's jump right into your study, and if you could move up to slide 8 there, thank you. Why don't we start and have you tell us a little bit about the patients that your team cares for and how you use data to support that care?
Sure, yeah, I think it's important to give a little background as to the clinical space where we're utilizing some of the technology that we're talking about today. The cardiac ICU I work at, again, is a pediatric dedicated cardiac intensive care unit, but unique in the sense that we take care of a full spectrum of patients from both the neonatal period as well as through adults who have congenital heart disease. I'd say the majority of patients are in the pediatric to infant range and even neonatal range, but we're up to about 54 beds now, as one of the largest in the country, dedicated to just treating children who have heart problems and children who are critically ill. And so that critical illness can be seen both before and after important and life-saving heart surgeries, but also in the management of children who have end-stage heart failure, life-threatening arrhythmias, and children who need long-term care to help their hearts after being born with congenital heart disease. We also deal with children who have acquired heart disease, children who may have problems that develop later on in life. And so it does keep us on our toes. We're seeing upwards of 1,450 to nearly 1,500 patients a year walk through our ICU. And our ICU is geographically spread throughout our tower here at Texas Children's Hospital. We call the Legacy Tower. And so it's geographically distinct beds on 3 different floors, which makes it quite challenging to sort of keep your finger on the pulse, no pun intended. So, what we're seeing is newborns and infants who are quite critically ill. They take up about 45% of our admissions. And a lot of these children, especially the newborns, are undergoing very complex surgical procedures. So our partnership across the heart center is really important with our surgeons, with our anesthesiologists, our cardiologists, and especially our cardiac nurses who are specially trained, in addition to all the ancillary support, our respiratory therapists, all the team that supports our mechanical circulatory support devices. And this is all 24/7. It's a 24/7 venture. It's truly a team sport. And in order to have a well-functioning team, we have to communicate well, we have to be able to monitor well, and that's sort of really what we're here to talk about today.
Well, that certainly sounds like a very challenging population with obviously some very life-threatening illnesses. You touched on it a little bit, but I wanted to get a little bit deeper into the monitoring of these patients. Tell us what's involved in detail in monitoring these patients, and how has that changed over time?
Yes, I think it's important before we talk about the monitoring to explain a little bit about the reason why we're doing this. And so, when children are born with critical congenital heart disease, their hearts aren't shaped like yours or mine. They tend to be somewhat weaker and require, specialized training and care that involves monitoring and recovery from certain corrective heart surgeries, unique knowledge of their very different physiologies and their immature cardiovascular systems, and a recognition that they are often the sickest patients in the hospital whose, when we say hemodynamic responses to interventions, or even just the way that their heart and their body are interacting, can sometimes fluctuate over the course of seconds to minutes. I think for those on the call who've taken care of patients like this, especially those higher risk neonates, patients who might have what we call single ventricle physiology, we've all seen a patient who seems to be doing okay have a rapid deterioration because of some inciting event. Either they're upset, they're trying to pass a bowel movement, or we've just done something noxious to the patient, like move them in a bed or try and suction out some extra mucus that might be building up in their mouth or their breathing tube. So managing these patients is challenging just to begin with. And as just the nature of any healthcare system throughout the world, our staffing changes over the course of a 24-hour period, right? And so, you know, there's a daytime and there's a nighttime, and the ratio of patients to providers, including physicians in particular, changes over the course of the day. And so there's almost a different heightened level of awareness that's required for teams, not only during the daytime for these really high risk, critically ill patients, but also at night. And you know, as you put on this slide here, exactly, it's exactly true. The ratio does change at nighttime, where you have 2 attending level providers covering the ICU at night, rather than just the 4 that we have rounding every day. And so we have 4 rounding teams per day, and that shifts to 2 at night. Thankfully, very thankfully, our nursing ratios don't change from day to night. They are our bloodline, they are our eyes and ears, and they really are our link to technology to allow us to empower the monitoring, the surveillance, and hopefully the anticipation for preventing clinical deterioration events.
Boy, that's great to hear. And you talk about real-time management of these patients and how fluid they are from moment to moment, how things can change, and with the staff that you have. And obviously that's crucial to avoiding these clinical deterioration events. But do you do any retrospective analysis of these patients? Can you take that data and kind of look at things over time?
Well, you know, I don't want to skip over the real-time element of monitoring, because, you know, when you're there taking care of these patients day or night, this is what you rely on, right? So you rely on good communication with nursing staff who can recognize potential changes and really try and anticipate the progress that a patient's going to make. We tend to default back to vital signs, of course, because that is the ultimate conversation piece when I'm trying to talk to a patient who is either too young or is incapacitated because they have a breathing tube or they're sedated. So I have to rely on my physical exam and their vital signs to tell me how they're doing, in addition to things like laboratory analyses. And the vital signs, where the rubber meets the road, is my ability to look at a monitor, a patient's bedside monitor, telling me what those vital signs are. And I cannot be in 24 beds at the same time. So I tend to want to have as many of those monitors available to me in real time as possible. And so we do use the multi-mon feature of sickbay, at least, you know, many of us providers do, whether we're at the bedside, either in the physician's workspace or in our call rooms, or even potentially at home, where we can actually select the patients we want to see. And this just displays their real-time bedside monitor in the fashion as, yeah, exactly, as you guys have listed here on the left. It allows me to visualize different elements. If I wanted to just look at certain ECG leads, I can click on that. If I want to look at their pulse oximetry waveform, I can do that. If I want to look at their blood pressure waveform, I just click on that, and it displays exactly what I'd be seeing if I was standing right by the patient. So that simultaneous sort of viewing of multiple patients has actually impacted care, in the sense that I've been monitoring a patient remotely and or multiple patients, and saw a clinical event or sort of a change that was concerning enough that I actually went to the bedside and actually met the nurse there, who happened to be next door with another critically ill patient. So we were able to sort of work together in a very rapid fashion to try and ameliorate the situation. But if I didn't have the eyes on the vital signs through multi-mon, I probably just would have waited for someone to walk by, or the nurse to finally arrive at the bedside, recognize what was happening, call me on my phone, and then I'd have to rush to the bedside. So I find this incredibly helpful from a real-time standpoint. Now, your question about looking at retrospective data, that's another incredibly important element of how we review and debrief important events, right? So, what we're trying to do in critical care is recognize patterns of behavior, patterns of vital signs, patterns in laboratory sampling, patterns in patients, and then try and pick up the right signal from that to help us potentially be a step or two ahead, right? So one way to try and improve pattern recognition is to take data and events that have already occurred, and then in a retrospective fashion, look at them, see like, okay, well, what happened first for this patient before they had, let's just say, a cardiac arrest. And so by using the patient HX view, I'm able to pull up different channels of whatever vital sign I'm looking for, and including things like dragging in laboratory data that was sampled at a specific time, pharmacy data. So I'm able to pull up heart rates. I'm able to pull up the actual ECG waveforms, ST segment changes, blood pressures, pulse oximetry. Now we're getting ventilator data, end-tidal CO2 tracings, and of course, arterial blood pressure monitoring. And you can just scan back, and you're not limited to a 72-hour window like our historic telemetry systems have limited you, where after 72 hours, the data is dumped and you lose the vital sign trends that the patients had, right? Because we're looking for trends in behavior, and if you're not able to look back more than 72 hours, it's not very helpful. We use this both at the bedside when we're trying to understand what just happened, if we had a near miss or a rescue, but we also use this for more remote debriefing of really big events like cardiac arrest, try and understand what were some of the precipitating factors, which is really hard to glean from traditional debriefing techniques, and trying to understand, hey, how do things go? What went well? What didn't go well? And oftentimes our memory, our collective memory of what happened is skewed and sometimes not very accurate in the heat of the moment in a very stressful environment like a cardiac arrest. So being able to look back in time and be like, well, actually what happened first was the heart rate dropped and then the oxygenation fell versus the opposite, can tell us a lot about the physiology that may have led to the arrest, so that hopefully we can prevent it from happening again.
Very interesting how you customize this screen, both with real-time data, depending on the monitor you're looking for, and historical data that we would have otherwise lost after 72 hours, right? Sounds like you're doing a lot of that customization.
Yeah, I mean, I think some folks may want to layer heart rate with blood pressure on top of each other, and then have ventilator data and then oximetry down below. Some people just want to see it differently. So there is a customizable fashion and an ability to even flag an event so you can look at it at a later time and share it with other folks.
Sure. So staying on this chart, Dr. Lasa, can you give us an example of looking at the data maybe on this screen where you observed this hemodynamics data and made a call on patient care? Anything on here you could point out to that effect?
Well, I mean, the screen on the right is interesting. That looks like a patient had a relatively rapid increase in that green tracing, which is the heart rate, with a corresponding increase in blood pressure, which are those red lines down below. The blue line gives you the pulse oximetry or oxygen levels of a patient. There seem to be a lot more fluctuations up and down with some maybe inappropriate reading of the device at the time or true low oxygen levels for a patient. And so this would be helpful for us because in a retrospective fashion, we can understand, well, something led to both an increase in heart rate and blood pressure with variations in pulse oximetry. And I would probably suggest that, this patient was agitated, was in pain, leading to these changes. But we've also seen the opposite, where we've seen certain sort of sequential changes in vital signs that then in retrospect, when we match it with things like either findings at the time of an operation, a cardiac catheterization, or God forbid an autopsy, we're able to match this up and help us figure out what was going on. I can recall situations, as I mentioned before, where I see a real-time change and I say, well, that's interesting. This patient's, heart rates have been averaging 120 to 130. Why are we 160 right now? And I'll be able to pull up the patient HX and look at the previous nights and see what's happening. And lo and behold, this, that time lines up with the time we weigh our patients, where they get them out of the bed and they move them around. And okay, well, that makes sense. Now, the intensivist in me just wants just get up and go see the patient, right? So you walk over there and you see that, he's out of bed, he's a little cold. The nurse is putting him on a scale, and there you go. That's why his heart rate is up. But that added surveillance, I think you can question whether or not it's impacted care, and it's hard to measure that, but it definitely gives me peace of mind.
Very interesting. So you're obviously parsing through a lot of data. Is there anything else you can add about how access to this data impacts the way that you care for patients?
Well, accessing it, I think at the user interface level has to be fluid, has to be quick and seamless. And I definitely haven't had any major challenges with that. We talk about a couple key elements with care of the patients, and then trying to make sure that the data is, making it back to the care team. And it's like a full circle, right? So the bedside nurse traditionally has inputted data into the medical record system, like vital signs, that then populate potentially sort of trend graphs of vital signs. They put notes in there communicating. They also, can trigger alarms and make sure that they're escalating to the physician providers. The early detection of those vital sign alarms and or changes in a patient's behavior or patterns can oftentimes be very, very minute to minute. So because that timing is so crucial, we want to be able to say that alarm triggers are communicated quickly, but sometimes the nurse is in the middle of 14 different things at once. I mean, incredible multitaskers, but they're oftentimes not able to do that 15th in a timely fashion. And so that's where the ability to have another set of eyes surveilling is really important. And so that access is in the form of a visual display, right? It's either the form of a mirror to a bedside monitor, a unique alarm, a color code scheme, something that allows folks to have a certain level of alertness and or awareness or concern, right? Sort of like a red, yellow, green, or amber, et cetera. I think the access to data is also important for the debriefing piece. And so if we don't talk about how we performed, if we don't review exactly what happened at the bedside, then we're never going to be able to improve what went well or what didn't go well, but also recognize, hey, these are things that actually went well, and we want to replicate that. And so that's why, exactly, solving the mystery of why is important in accessing the data and having it fingertip ready real time, rather than having to put a request into the data team. I need to pull these vital signs for this patient for the past week. I want to see their heart rate trends for the past week, and then waiting 2 days to get that. Now I can just pull it up within the mere seconds and see exactly what's been going on for the patient.
Yeah, pull it up within mere seconds, as long as it hasn't been discarded over the last 72 hours, right? So same issue of having the data longitudinally. So very, very interesting the way you have command of this data, how you can get at it and make really what sound like life-saving decisions there. So tell us what's next. What are you hoping to do with the data you have now going forward?
Well, I think there's a lot that we've now been given in terms of the fundamental building blocks of trying to understand how our patients are behaving at a lot more granular level. Now, in the past, we've been able to sample vital signs, that are typically human entered and or somewhat human overseen, but pulled from vital signs at a frequency of like once an hour, or maybe once every 30 minutes. We're seeing things now at 0.5 to 2 hertz, or every 2 to 5 seconds. The data is coming across. So is that too granular for the bedside? Maybe, in the sense that we're going to be making decisions at the bedside anyways, looking at that. But, how does the capture of that information translate? And I think that's what we're trying to get at for the next couple of steps, right? So the historical model was human-based. Now we're getting things at a much more granular, frequent, and high fidelity basis. And it really just puts us sort of at an old model and a new model, and how we integrate the two is really important. So here at Texas Children's, we've really tried to make sure that access to real-time data as well as historic data is available for everyone, right? We want to make sure that it first starts with access and then education. But if we really want to take the next steps, we need to integrate some of the clinical data that our patients are producing, not just their vital signs, but who they are, ages, demographics, understanding their diseases and categorizing them. And then also trying to bring in things like pharmacy database, exposures to medications, timing of those medications, laboratory data to try to understand in a more real-time fashion how things are changing, blood gas monitoring, et cetera. And that's really the exciting thing for us. So we want to try and be able to bridge the two worlds. and really hopefully make some leaps and bounds in terms of understanding the impact of therapies on our patients on a very acute basis. So a very physiologic experiment. We're not saying, well, what factors led to the reason why this patient was readmitted to the hospital? And those are things that are going to incorporate things like socio-demographic factors, their age, comorbidities. We're looking at, well, what's going to lead to a 2 standard deviation increase in the blood pressure when you give a medication? So that's a key example. And I think, it's what's definitely driving me and some of our current research ventures here, and to try to understand and leverage the data.
Well, being on the front lines like you are, I can certainly see how you want to use this data to make better real-time decisions. I wanted to kind of turn your attention a little bit to the research side for a second and say, how are you using this data to collaborate and advance research in this area?
Well, like I mentioned, the intersection of what we do to a patient and then how they respond is really, really exciting to us. We oftentimes will start medications in the hopes that we're going to see a response, and we have this selection bias and provider bias that we all have in our own brains that, oh, well, I started the medication, so yeah, therefore I see an improvement. Well, what does the data show? And a good example was the use of a specific medication called vasopressin for a patient population that's one of our highest risk neonatal population in terms of their likelihood of having a clinical deterioration event like a cardiac arrest. And so the use of this particular medication has grown in popularity, and it kind of goes against some of the basic physiologic principles of what medications you should use for this physiology. And so we wanted to prove to ourselves that, well, we're using it more, but what's it doing to our patients? And we wouldn't have been able to do this without the sort of granularity and the frequency of blood pressure readings that we were pulling off a monitor through sickbay. And so that's just one example. We've already translated some of that data for 2 other previous analyses that have been published looking at Tylenol's impact, IV Tylenol in particular with hypotension in our cardiac intensive care unit, as well as what about those times where nurses are changing a very important infusion of a medication, in this case, epinephrine or synthetic adrenaline. And then what happens when we change that syringe in terms of the support for the patient's heart and blood pressure and cardiovascular system. So those have been published. We're hoping to get this particular analysis of vasopressin published soon. And we're moving forward to other interactions with not only this patient population, but other subpopulations, patients who may have biventricular circulations, exposure to different medications like calcium. And in particular, what does a blood transfusion do to a patient with regards to not only their hemodynamics, but their electrocardiographic signal as a potential marker of myocardial stress. And so these are all some potential avenues that having this granularity, this level of granularity allows for in terms of our what we're calling our hemodynamic work study group.
Wonderful information, Doctor. Once again, we're talking to Dr. Javier Lasa. Dr. Lasa is an attending physician in the cardiovascular intensive care unit at Texas Children's. And at this point, Dr. Lasa, I want to thank you again for all this fantastic work that you're doing in the area of neonate hemodynamic care. And I think we've had some questions come in from our audience members. And now I'd like to turn it over to Mr. Rajin Patel, who's MIC's Director of Research, to help moderate and facilitate those questions. Raj, are you there?
Yes, Bruce, can you hear me?
Yes, I can. Off you go.
Wonderful. So those of you in the audience, please follow the instructions in the slide that you see and put in some questions. We've got a couple come through already, so I'm just going to start. Dr. Lasa, you're doing a lot with hemodynamics, which is traditionally signals from the cardiac devices. In addition to those devices, what other devices do you find you need the signals from at the bedside?
Right. So I mentioned the ability to start pulling in ventilator data now. So we have, tidal volumes, we have compliance, we have end-tidal CO2 tracings coming in through the ventilator, flow rates. That's just, sitting there waiting for more questions to be asked. I think a lot of us have always envisioned sort of, well, how can we predict certain events? And in particular with the predictive analytics, that's really the next frontier for us and there've already been publications on this in terms of trying to predict extubation failure, but having granular waveform data is going to take it to the next level. We utilize a technology called near infrared spectroscopy almost on every single patient in our cardiac intensive care unit. It's another measure of the level of oxygen in venous blood coming back to the heart. And it gives us sort of a proxy of how well the heart's pumping. And so when the level's low, we're more concerned about the patient and the patient's heart. Is it struggling? Is it weak? And do they need medications and or even more advanced therapies like mechanical circulatory support? So we use that a lot, and we try and tie that into our understanding of, for example, pharmaceuticals and how they're impacting oxygen delivery to the heart and onto the body. And so using NIRS and trying to get that into the system has been our last year's adventure in terms of sort of adding that to the data set that's sitting in the sickbay servers. And so that's really exciting, being able to tap into NIRS data, because it opens up the ability to ask a lot of questions, not only about sort of the big events, but even about things like just minute-to-minute management, changes with regards to ventilation, et cetera.
That's really cool. Yeah.
Future potential devices. Well, we've integrated some non-invasive cardiac output monitoring like the Pico, FlowTrack, et cetera. And so trying to get that in is going to be really helpful. And then, of course, the data coming in from ventricular assist devices is another frontier. And in terms of our ability to understand how our patients are behaving, since we do have a decent number of patients who have VADs.
Very cool. Yeah. So these sound like useful devices to incorporate into the data set. There's a question coming in through the Q&A. Moving to clinical workflows, you'd mentioned being able to see this data for yourself. How is being able to see this data, how is sickbay affecting the current workflow of the bedside nurses or the RTs or intensivists?
Yeah, I mean, I think it's important for the audience to know that sickbay, it isn't a standalone monitor, right? And so there are other systems out there that have a separate monitor that sits in the room or at the bedside or on a wall that displays vital signs sort of over time. It's a web-based interface. You can pull it up anywhere, but it's not sitting there staring at you in the face. And so in that sense, it's not really impacting the workflows from the bedside nurse, RN, RT standpoint. It's mostly at the physician level now, but it's a good question and one that we ask ourselves a lot in terms of, is the value increased exponentially if you have it so everyone can see it? The problem is that it's, you have to decide on a predefined window that you're viewing, right? And so is it going to be a 12-hour trend? Do you want to do a 24-hour trend? What's the right trend view? And we haven't really gotten to that yet in terms of understanding what the right view is. At this point in time, we feel like the customizability and ability to look back whenever you want is an advantage. But in terms of having that accessible for nurses and respiratory therapists is still sort of a next step for us.
That makes a lot of sense, right? You want it to be as useful as you can and not have it impede on anybody's, day-to-day work, for sure. We've got, I think, time for one more question. And this is rather lengthy, so I'm gonna paraphrase it a little bit. Do you feel like remote monitoring helps with increasing safety in monitoring patients? This ability to free monitoring from the bedside or from pods and stations?
Well, I think for the bedside nurse that's staring at the monitors anyways, I'm not really sure how helpful it is, right? Because it's not really their responsibility to be worrying about bed 1412 that's around the corner, right? And so I think for those teams and individuals who are responsible for them, including the physician staff, frontline providers, having access to the full unit, now that we're geographically separated, is really helpful. Now, can I prove that it's improved safety? At this point in time, I'm not sure I can. It's really hard to do, given how hard it is to deal with all the other factors and controlling for those. But I definitely agree that it has increased my team's awareness in terms of how patients are behaving, because I could be rounding at a bedside, a complex patient, and I'll say to my teammate, hey, would you mind pulling up 1612's monitor on sickbay? Because we had just made a quick change on something and I want to see how they're doing. Rather than having to interrupt rounds, walk all the way to the other side, see how they're doing. I can see oxygenation, blood pressures, et cetera. And so that situational awareness, which in some ways can be lost when you move to a larger geographically separated unit, can be mitigated, I think. But it's really hard to prove that.
I take a lot of comfort in the fact that you want to be really sure of how these changes in workflow will actually take care of patients before you implement them. I think that's exactly the right way to go about it. I want to be respectful of everybody's time, and we're hitting the 1 o'clock mark. So I'm going to throw back to Bruce. Bruce?
Very good, Raj. Thank you very much. And again, Dr. Lasa, thank you so much for all this great info and all the great work you're doing for this very critically ill population. And as a reminder to everyone in the audience, we will make Dr. Lasa's research, a replay of this webinar, the Q&A, and an audio podcast version available after this webinar. And we'd like to thank you again for joining us in this edition of our Healthcare Data Matters webinar. We hope you can join our next session on November 10th, where Dr. Parag Jain, also from Texas Children's, will be discussing how he and his colleagues are automating the detection of JET, otherwise known as junctional ectopic tachycardia, to get ahead of risk in pediatric populations. In the meantime, you can visit our website for more information or check out our associated social media channels. Thank you again for joining us on Healthcare Data Matters. We're grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care, everyone.
Thank you.